IgM negative, IgG positive.
Okay.
Yeah.
Excuse me, Dr. Amagid. I prefer in such a situation when we have a possibility of rejection and the patient is febrile and whether I know that he is CMV or not, try to bypass the ATG, and I think IVIG would have been a better choice. It would bypass any infection, any TMA or CMV itself.
Yeah.
And we can encounter CMV very early in the transplantation, even in the first month. And the crucial treatment in such a situation, which would save the patient, is the IVIG, preferably CMV IVIG, which is not available in Egypt.
Thus we continue. If we continue as the case, we have had.
What is the comment on the blood film in the first time and second time regarding any changes in the vessels and the thrombocytopenia? Last time it is clear, but what about the first time? Do you blood film for these patients
for
each
the
time?
second time?
Yes.
We did.
What
for
about
the
the cells?
Yeah, it is okay.
No fragmented
RBCs.
cells. No fragmented cells.
No
but your LDH is high.
What?
LDH is high.
That's why we said there is a very simple test to suspect antibody-mediated rejection. For me, LDH, when it rise, I did blood film to show is this circulatory trauma in the RBCs or the endothelial defect. So LDH
but
was
we could expect
me,
some fragmented cells if there is blood film that had been examined thoroughly.
Yeah, but no fragmented RBCs.
Thank you.
Okay, so the second
Shall we
biopsy
start?
was done?
Yeah. Should I continue?
Hold on.
Okay, so the second biopsy this time had 9 glomeruli and two arteries. There were remarkable tubular injury, as you can see. There were only very few foci of tubulitis, which were rather insignificant, but you can also see that the interstitium was starting to be affected, and there were remnants of lymphocytes. Again, the glums didn't have anything. I had nothing suggestive of thrombotic microangiopathy in the biopsy. There were this evident tubular injury, and there was fibrosis, as you can see with the trichrome stain, which affected around 30% of the biopsy we got. And look at the peritubular capillaries. The peritubular capillaries were dilated, and they had focal mild capillaritis, just a couple of cells every now and then. It wasn't really significant. There was nothing else in the biopsy, so it was an acute tubular injury. You had early fibrosis and some lymphocytic infiltrate, which was related to the fibrosis. No more evidence of an active cell-mediated rejection or of a viral infection, but his C4D this time was positive. But you can see the C4D was positive. What's the C4D? This linear staining along the peritubular capillaries, and the C4D positivity was actually a focal positivity, meaning that it was affecting between 30 to 50% of the biopsy. So this time it was compatible with an acute antibody-mediated rejection, C4D positive, MAF type grade 1. We had only minimal inflammation and no remarkable peritubular capillaritis. And following the biopsy, they have repeated the PRAs, and they had a 27% reaction at the DQ7, right?
Yeah, it's hard.
So patients received 5 sessions of plasmapheresis, half-gram steroids, cyclosporin was replaced by TAC, and rituximab was administered for 2 doses. He had normalization in his serum LDH, and platelet count was achieved after 1 week. 3 weeks later, he was discharged with hemoglobin 10.8 and serum creat 1.7. He was maintained on prednisone, MMF, TAC, and Valgang cyclovir. Till 1 week ago, his serum creat is 1.6, and the patient is doing fine. Well, the whole take-home message out of this case is that acute antibody-mediated rejection is a common incident, even not only very early post-transplant. It doesn't have to occur in the first week or 2 weeks. It can occur at any time post-transplantation, actually up to few years. Focal C4D positivity, which is what we score out of the peritubular capillary, from 30% to 50%, could be missed on a small inadequate biopsy. I don't know if the patient was already C4D positive from the first biopsy. A focal C4D positivity, if you are doing it by immunoperoxidase and not immunofluorescence, equals to diffuse positivity, because we agree that immunoperoxidase is 1 degree less sensitive than immunofluorescence. So a patient with a focal C4D positivity should be treated if he has DSAs as well. And always remember that transplant patients do not usually follow one track, and that they come presenting with multiple affections. Thank you.
أيوة يا باشا. أيوة يا باشا. For me. لا استنى يا باشا. ما تمشيش. إيه؟ أيوة عايز أسأل عشان أبهدل نفسي. أيوة يا باشا. I ask our eminent pathologist two questions. The first, why C4D is specific for the peritubular capillaries only and do not appear in the glomerulus, and the vice versa, immunoglobulins didn't appear in the peritubular area and appear in the glomerulus.
Well, no, I don't get the second one. What's vice versa?
Why immunoglobulins, we can't see them in the tubular area and we found them in the glomerulus?
No, the immunoglobulins,
and the vice
we see
versa.
them, no,
Because
immunoglobulins, we see them in the tubular areas, but the significant ones we're looking for, if you're looking for glomerulonephritis, is in the glomeruli. But if I'm looking for immune-mediated tubular interstitial nephritis, for example, I would be interested in the immunoglobulins presented around the tubules. So it depends where am I looking for them. For the other thing, you do see C4D, there is an overspilling of the complement, so you do actually see it in the glomeruli, but we don't come on it because we agreed that that specific one is in the peritubular capillaries. But in cases of the acute cases and high activity, you do see the same staining around in the glomeruli.
May I ask a question about the specificity of the site of the C4D positivity? Is
Sorry,
it related
I didn't hear you.
concerning the site of the C4D positivity, whether it's only peritubular capillaries or concomitant with the glomerular deposition?
The glomerular positivity till now has no significance.
Okay, so it's,
if I have only glomerular positivity, I wouldn't consider it significant. I wouldn't consider it positive.
but you in antibody-mediated rejection, you find them in the peritubular capillaries, not in the glomeruli. So this might be related to specificity of tubular antigens to the antibodies which are produced. It's
But
not
in
only an overflow.
antibody-mediated rejection, you can see them in the glomeruli as well as the peritubular capillaries.
Yes, but occasionally you find them only in the peritubular capillaries with negative glomeruli. So it seems that the tubular antigens are crucial in the site of the deposition.
لو سمحت
Trauma.
Of the CNI as well as all that.
Yeah.
Is there an element of CNI toxicity which may also explain the recovery? Because as Professor Ponticelli was saying, an antibody-mediated rejection doesn't respond so easily and so quickly and normalize its creatinine. Dr. Volker, would you like to comment on the C4D positivity and...
I agree that focal C4D positivity should also alert the clinicians that antibodies play a role and injure the graft. Now, I'm a little bit opposed to the general term of an antibody-mediated rejection. That reminds me of the patient has cancer. We have to know more about it. And there may be mild antibody-mediated rejections, and there may be very dominant antibody-mediated rejections, later characterized by V3 lesions with fibrinoid vascular necrosis, interstitial hemorrhage, and infarction. We have not seen that here, so that would be my assumption that, yes, antibodies do play a role in this patient, but no, it is not a very striking or dominant form of an antibody-mediated rejection, and that can also explain why the response was favorable.
Yeah, it's just a very mild, only presenting with the tubular injury. Possibly there is also injuries, but it's a very mild thing.
And really, it's a continuum. I mean, we know very little about antibody titers that are associated with antibody-mediated rejection. Are there different classes of antibodies that do different things? All that knowledge is extremely rudimentary. So right now we just have the term antibodies play a role, and I think in our heads we should try to figure out, is it a very striking event or a milder event, and here, as I said, this is milder.
But there was an anti-DQ7, wasn't there? There was a circulating
Yes.
donor-specific antibody.
That proves the point, yeah.
We're running out of time, so a very, very quick question, Professor Omar.
Well, it's just a comment. I think the first event is not related to the second event. The first event is clearly a cellular rejection that responded to, that was steroid resistant and responded to ATG. The second event, I cannot classify it as anything, as a matter of fact, because acute vascular rejection, this is not the biopsy picture. And chronic vascular rejection, this is not the course. It does not occur in 20 days or 1 month. Anyhow, I think this patient is over immunosuppressed, and I would advise to gradually reduce the immunosuppression. This patient has a continuous CMV status, activity status.
But if he has call it an antibody-mediated rejection, you want to be cautious as well not to under-immunosuppress him. So, difficult case. We better move on. Thank you very much. So, Dr. Volk, are you presenting the third case, please?
Dr. Megid, pardonnez-moi, sorry. Dr. Megid, but I have a comment. I search for why C4D is specific in the peritubular region. Why I think that all of us wanted to know how. Yesterday, I know why. It is specific for C4D. I ask a question, I have an answer. If we found the glomerulus, there is 4 inhibitors, protectin and the decay accelerating factors, many factors present in the glomerulus, neutralize immunoglobulins and neutralize C4D. And when you use complements, they use from C5 to C9 only, not C4D. C4D split in this area, in the peritubular region. And there is no neutralizing antibodies at this area. So it predisposes staining and I am asking the pathologists why the staining is present in this area only. We found that splitting factor of complement C4D is present in the area and it didn't present in the glomerulus.
Thank you very much. The army always has the last word. Thank you. Okay.
Okay, since I was not fully aware of the format that the cases are presented, this format I have assembled here differs, and we will be faster. Now, the case I brought here is that of a 77-year-old African-American male who was managed at an outside institution, so not in Chapel Hill, and that already tells you that the information that we had received at time of biopsy was somewhat limited, so usual everyday case scenario, more or less. We know that the patient had suffered from long-standing diabetes mellitus, lost function of the native kidneys due to a diabetic nephropathy, and developed end-stage renal disease. He was transplanted in October 2012, so quite recently, and received a renal allograft of cadaveric origin. At the outside managing institution, reportedly a previous allograft biopsy was performed and showed hypertension-induced changes. That means arteriosclerosis, some degree of interstitial fibrosis with tubular atrophy, and no rejection. Of course, based on the timeline here, and the fact that the patient is older, that he had received a graft of cadaveric origin, it is really fair to assume that all these chronic changes seen in that first renal allograft were donor-related, so donor disease, a thing that we see quite frequently in by far more than 50% of all biopsies performed early after transplantation do we find chronic donor-related changes. So something to keep in mind. So no rejection. Then the patient was immunosuppressed with the usual suspects, Cellcept, tacrolimus, steroids, predisposing this patient, of course, already for polyomyelitis nephropathy if you just play the odds that the patient received TAC. Now, his baseline serum creatinine levels were 1.5 milligram per deciliter, so not very good, but acceptable. Also considering the knowledge that there was substantial donor disease, and if you have substantial donor disease, serum creatinine levels will never go down to normal, to 1.2 or 1.1. They will always be elevated as the best baseline readings that you can get, in particular if you have pre-existing arteriosclerosis. Now, all that was fine when he peaked again with acute allograft failure, so to speak, with serum creatinine levels of 3.7 milligram per deciliter. As usual in these cases, early after transplantation, there is no hematuria and no proteinuria. So at that time point, a renal allograft biopsy was performed, and as I told you, that was all the information we received. You're all familiar with the fact that then you surround the usual suspects. You suspect, of course, rejection. You can question whether the patient was compliant or not, which is a big issue, especially in the pediatric population. We do not know anything about the tacrolimus trough levels. In theory, at least a functional calcineurin inhibitor toxicity can be entertained, and something else, of course. Okay, so I think there is no big need for discussion here, since basically the differential diagnosis is pretty straightforward. Now, that is a low-power view of the second renal allograft biopsy. And maybe just a question, is it the same as the reported first one? Would we think that this is donor disease here with chronic changes, or what do people suspect, if anything?
Looks like acute cellular rejection.
Yes, and that is based on what?
I mean, we don't have high power, but there is a severe interstitial infiltrate, isn't it?
Well, I only have a pointer here and can point to the left screen, and you are in the line of fire here now. But you see here in that low power image, that's absolutely correct, that there are too many infiltrating cells here in the interstitial compartment, and that the overall picture, the gestalt at this low power is too busy. We also appreciate here on this low power that there are no vast zones of chronic changes. So at least what we see here, there is not significant chronic injury in this field. Now, of course, you get some help and you have the higher power that you desire. And what do we see? What was the low power assumption? That we are likely dealing with a rejection episode, potentially with a cellular rejection episode, correct? And if so, what is it based on? What is this structure here? It's a PAS stain, which we routinely use in order to bring out the basement membranes better. And of course, we see here a tubular basement membrane right there. And then there is one cell. We have other tubules here and another tubule here. So the tubules are separated from each other by an predominantly mononuclear lymphocytic infiltrate. And that in a graft, as you all know, is not very good. If you have too many round blue cells, then normally you are dealing with a rejection episode. That gets supported by the fact that there is quite a lot of interstitial edema, which is usually associated with a vivid, active, and acute inflammatory process. We have that here. And then, of course, once these cells, the lymphocytes, cross the tubular basement membranes and lie between tubular epithelial cells, so-called tubulitis that, as you all know, is a hallmark of what is termed tubulointerstitial cellular rejection, or for those who love the Banff scheme, Banff type 1 rejection in the category 4, as of now, all we know. Okay. Yeah. Now, maybe take it a step back. If you were a renal tubule, let's assume you are a renal tubule for a moment, and of course you would be nourished by your partners, the peritubular capillaries, that pump all the oxygen towards you and keep you happy with all your work that you do. Now, as soon as your partners, the peritubular capillaries, are separated from you by the buildup of interstitial edema, then of course you will get less nutrients, less oxygen, and you will suffer from what is termed acute tubular injury, or in the old term, acute tubular necrosis. So what I'm driving at is, of course, that if you have so much active interstitial disease with edema, infiltrates, that means that the tubules cannot be happy anymore. They are not happy campers anymore. And that you will see certain degrees of acute tubular epithelial cell injury and regeneration, and that is characterized by enlargement of nuclei. Some nuclei look a little funny, and in some cases that can get bizarre, meaning that we have no good handle in that very moment whether we have an infection or not, whether we are looking at viral inclusions or not. Case is a little similar, or the tubules are a little similar to what Dr. Ismail just showed in the last case. So yes, the nuclei look a little funny, but no, I do not see compelling nuclear inclusions here.
5 more minutes, we've run out of time.
Oh, okay, good. I will hurry. So the next thing, of course, that you have to ask is, what is another compartment in the kidney doing here? And the other compartment is, of course, you always should search for and ask the question, is it normal or abnormal? What are the arteries doing? And arteries is characterized by interlobular type arteries with at least 2 layers of smooth muscle cells. So that is the caliber you really want to look at. And now, normal or abnormal? I take votes. Abnormal, exactly, I agree. And what is abnormal? That is absolutely correct. So we have too many circulating lymphocytes, and some of these lymphocytes have crawled under the endothelium and called what we term transplant endarteritis. So there is no transmural inflammation, no fibrinoid necrosis. So that, per definition, will take us into a more severe cellular rejection episode that can only be diagnosed by really looking into the arteries, and that now would be a Banff type 2 rejection, 2A rejection, for the Banff lovers among us. Okay, good. What else do you want to know now? And you're all experts, especially to my left. C4D, you must know the C4D staining status in order to get at least some idea whether antibodies are involved or not. And the C4D staining status is negative. Okay, so at this time point, we would be all happy, said yabba dabba doo. We have a diagnosis, we can explain everything, and the acute renal allograft failure is due to the severe cellular rejection episode. We normally do a regular panel of antibody stains by immunofluorescence staining. That panel, I don't show you that, was negative, so no IgG, no IgA, no complement factors, no light chain deposition. Now, but renal biopsies often give you answers that you don't want to see. And that is now one field here. I know that I'm under time constraints, and pretty soon I will be pushed off the podium. So let's move forward, and the question is this here compatible with the diagnosis of tumor interstitial cell rejection, and what is it?
Is it like, can you go back? Is it, I thought,
I like it. I like you, Elvis. You must be my colleagues, yes. Yes, there is an aggregate here that is pretty densely arranged, pretty sharply demarcated, and all these cells look sort of funny. In the old descriptions, they were called a cat tongue-like. Well, don't ask me where that came from, but that refers to so-called epithelioid-looking histiocytes that form granuloma. Now, the funny thing is that in some cases, you can even find these peculiar funny granuloma type of things in extended tubules. And that's what we have here. For those with eagle eyes, you can see a very fine blue line in this trichrome stain. That is the extended tubular basement membrane here. And these tubules are just filled with these peculiar elongated cell elements, many of those histiocytes and some epithelial cells. Now, to cut a long story short, that is incompatible with just a diagnosis of cellular rejection, but is one possible sign of a polyomavirus infection. And now, if we do the SB40 stain here, the SB40 stain was positive. So we had, no, hold on here. Here it is. They were not only angry, that is correct, here, and there is another tubule potentially with an inclusion body right here on the left and then injured. So that means we have two diagnoses here. And remember, during the presentation, I briefly touched upon that polyomavirus nephropathy can concur with rejection. And here we have very good evidence that there is a concurrent rejection episode based on the fact that we have transplant and arteritis. Transplant and arteritis is incompatible with the diagnosis of polyomavirus nephropathy. If you have endarteritis, there is a component of rejection here. And then, of course, in this case, we also have, in addition, concurrent polyomavirus nephropathy stage B with a relatively high viral load. So in the end, I think your suspicion that some of the nuclei looked too funny was absolutely correct. So the question for you now, and I want to cut the long story short, and not take too much of your time. What now? And ideally, and that is based on anecdotal case reports, there are no case series really supporting that, but anecdotal evidence suggests that treatment of the rejection aggressively as a transient form of over-immunosuppression is okay to get a grip on the rejection, and then as a second approach, second step, try to deal with the polyomavirus nephropathy, give fliflunomide, try maybe to replace tacrolimus with cyclosporin, and of course in this whole scenario be very cautious. Most clinicians, of course, are very fearful now giving over-immunosuppression in a patient with an active viral disease. And that in general is, of course, absolutely correct. However, does not really fully apply for the scenario of polyomavirus nephropathy. And you may remember, number one, polyomavirus nephropathy is limited to the allograft. The worst case scenario is that you lose the graft. You will not lose the patient due to polyomavirus nephropathy, very different from CMV or adenovirus infection. Number two is if you don't act with this combination, then of course the graft is doomed anyway. So you are fighting with your back to the wall. Now, in the literature, and this is an article from 10 years ago in the New England Journal, you see that they had published, and the pointer here is very, very weak, they had published two patients with polyomavirus nephropathy, and you see in the upper rows the treatment that was applied administered in those patients. The patient got bolus steroid therapy and also ATG. And you see that the solid line, and that is why I'm showing this case, shows the viremia level based on PCR analysis. And the punchline, the take-home message from these two patients is that even the addition of immunosuppression, even the addition of ATG in these patients did not result in a catastrophic multiplication of the virus and increase of the viremia levels. meaning the viremia levels stayed more or less unchanged, and in the end even were lower or even came down to zero. So transient immunosuppression, at least not necessarily in all cases, have to result in an explosion of viral replication. And that is the reason why we suggest to really treat the rejection episode transiently and then do some baseline adjustment of the immunosuppression in order to treat the polyomavirus nephropathy. This patient received bolus steroids, which may be okay. This was a type 2A rejection episode, so the transplant endarteritis was not too severe, and IVIG with the idea to treat the polyomavirus nephropathy a little bit and also do something with the rejection episode. Maybe a questionable approach. Interestingly enough, as you see here, the serum creatinine decreased to 2 milligram per deciliter after therapy. Subsequently, the serum creatinine levels rose again, but that was in the scenario that overall the immunosuppressive regimen was not changed. And of course, you can assume that the rejection episode was treated somehow with a bolus steroids, but the polyomavirus was not, and that results now in the deterioration of graft function. Now that is the last follow-up we have from this patient, and I do not know what the most current readings are. And I think for the sake of time, I will stop here.
Thank you very much, and thank you for all the speakers for these 3 very interesting cases. Thank you. This concludes the session. Thank you very much.
Sponsored by Sanofi is Dr. Frank Strauss, who is the head of the department of the German Clinic of Diagnostics, and he's going to give us a talk about the significance of prevention and therapy of vascular calcification. I think it's a very hot topic. Frank.
Yeah, thank you, Mr. Chairman.
We're happy to have you.
Ladies and gentlemen, it's a great honor for me to be here and to talk about the problems of vascular calcification and what we can do about it in our patients. This slide shows the causes of death and end-stage renal failure. And as you can see, those causes are not that different, and of course you're all aware of that, not that different from the general population. The cardiovascular causes of death are by far the most prominent. However, what is different from the general population is that the occurrence of this cardiovascular mortality is much higher compared to the general population. This slide shows the 5-year survival rates on hemodialysis, and you can see, compared to many other forms of very severe disease, our patients on hemodialysis have a very poor outcome. The cardiovascular mortality in our patient is robustly increased. And to ask you a question, to put this point into perspective, what do you think is the difference in mortality between a 20-year-old patient on hemodialysis and his healthy peer? Is it increased by a factor of 2, by a factor of 10, by a factor of 100, or is it increased by a factor of 500 to 1,000? Now everybody can think about the response, and the response, in fact, as shown on the next slide, is in fact it is increased by a factor of 500 to 1,000, showing again the real importance of cardiovascular mortality in our patient, and that this risk to die is so much increased compared to the general population. And in fact, Why is that the case? The problem with our patient is often that the vessels are really much more aged. They have much more calcifications compared to the general population, as illustrated nicely in this cartoon. Where do we find these cardiovascular calcifications? Well, you can find them on regular chest x-rays, as shown here. The aorta is solidly calcified. You can find it in the aorta of the abdominal area if you do a lateral abdominal x-ray, as shown here. You can see it in the vessels of the iliac arteries, and that is something that's becoming more and more important, because those are the vessels where the surgeons need to connect the artery of a new kidney to if the patient needs a kidney transplant. In fact, 2 weeks ago, I had 2 of my patients who could not get a transplant, although they had an offer for a kidney, because their vessels of the iliac arteries were so much calcified that the surgeons could not find any place where to connect the new kidney to. So it is a real problem for our patients. And finally, of course, you can do echocardiography, you can do a regular ultrasound of the abdominal area and still look for calcifications. And every time you find those calcifications, it means that the patient who already has a highly increased risk is at even higher risk to develop any form of cardiovascular morbidity and mortality. Where do these calcifications occur? Well, they occur regularly in the intima, as it does in patients without any forms of renal failure, but it also occurs in the media. Now, there's a long discussion in the nephrologic community which of the 2 forms of calcification is more important, which poses a higher risk. In the end, I don't think it really matters. It matters if calcification is present, being it in the intima or in the media, it always predisposes that patient to a higher cardiovascular risk. And just to show you the relative increase in risk compared to the traditional risk factors we have in the general population, such as hypertension, inflammation, high cholesterol, the increase of risk if vascular calcification is present is much higher compared to these traditional risk factors. That is true for the general population. There's just one study here where they looked at the coronary calcifications. The higher the coronary calcium score, the higher the risk of any cardiovascular event, as shown here. And those patients with the lowest amount of calcification or no calcification present, those patients had the lowest risk. That's also true for our hemodialysis patients. In this study, they differentiated between media and intima calcification, but I don't think, again, that matters in practice. And it also matters in patients with chronic renal failure, as shown by this study from southern Italy. Patients in chronic renal failure, those that did not have vascular calcifications had a very neglectable cardiovascular risk, whereas those where cardiovascular calcifications were present had a highly increased risk for such an event. How prevalent are vascular calcifications in dialysis patients? This is taken from a study in Scandinavia, in Finland, where they did a lateral X-ray of the abdominal aorta and looked at the number of segments of the aorta affected. And you can see only about 20% of all dialysis patients did not have any vascular calcification. 80% had, And most of those patients who did have vascular calcifications, in fact, had a high amount of vascular calcification, meaning that all four segments of the abdominal aorta were affected by vascular calcifications. What are the consequences of vascular calcification, be it in the intima or in the media? Well, both in the end will result in infarction and ischemia. The risk for those events is highly increased by both events. So what are the conclusions of this first part of my talk? There's no question that vascular calcifications are associated with highly increased vascular mortality in patients with end-stage, but also in patients with chronic renal failure. Vascular calcifications are highly prevalent, up to 80% in patients on hemodialysis patients, and they are very important in preventing kidney transplantation. So it's very important for us to prevent those calcifications if we want to have our patient transplanted. What causes now these vascular calcifications? Well, there are many factors involved, but the most important factor in the increase of vascular calcification is a high level of phosphate. This all changed, this paradigm pointing phosphate into the middle of vascular calcification changed a couple of years ago, or now 15 years ago, in fact, when Block et al. Looked at large databases from the Fresenius registry in the United States, over 60,000 patients on hemodialysis, and they looked what factors predispose these patients to an increased risk to die. And they found that the product of calcium and phosphate was one of the most important factors if it was increased to also increase the risk of cardiovascular mortality. And later it turned out that phosphate was the most important factor. As it is shown very nicely here, phosphate is basically in the center. How does phosphate result in increased calcification? Well, it can result directly in vascular calcification via pyrophosphate or hydroxyapatite. It can result in apoptosis of endothelial, but also smooth muscle cells. And maybe the most important factor, it can result in a differentiation or transdifferentiation of vascular smooth muscle cells to a more osteoplastic-like cell. And in fact, the group by Stripoli 2 years ago looked at the various risk factors, and this group is known to be very critical, but even they came up with the conclusion that there is not that much evidence for being calcium or parathyroid hormone as a risk factor associated with death and cardiovascular events, but even they had to admit that there is a clear-cut association between higher levels of phosphorus and mortality in patients with renal failure. And this shows in a little bit more detail the mechanisms how phosphate acts in vascular smooth muscle cells. And you can see if phosphate is increased within the vascular smooth muscle cells, it basically results in a downregulation of vascular smooth muscle cell specific genes and results in an upregulation of osteoblastic specific genes such as alkaline phosphatase, osteocalcin, osteopontin, and there's possibly also an increased synthesis and secretion of various collagens. There are numerous experimental data, and this is actually taken from a study from Jack Kelly's group in Seattle, published just a couple of weeks ago, where they treated mice with chronic renal failure with a high diet in phosphate. And you can see if these mice had chronic kidney disease and a diet high in phosphate, they developed vascular calcification, independent of the calcium level. And this has also been shown in clinical studies. This is a British study where they looked prospectively at over 100 patients and looked for the development of coronary artery calcification in patients with stage 3 and stage 4 chronic kidney disease. And they found that the progression of coronary artery calcification was highly correlated with the level of phosphate. And now we're talking phosphate level which are still within the normal range, meaning that even within the normal range, the higher the phosphate level, the higher the risk for the individual patient to develop vascular calcification. This slide shows you the physiologic balance of phosphate. Usually, at least in a westernized diet, it may be a little better in this country, the usual phosphate content is about 1.2 grams per day. Of that is 1/3 being excreted with the feces. 2/3 of it is being absorbed and excreted with the urine. Now that's the normal physiologic situation. What happens in patients with renal failure? Well, in that case, of course, the excretion of the urine is diminished, and that meaning that there's a new department which opens up, the cardiovascular department, the vessels. There's an increased intake of phosphate into the vessels, particularly into the vascular smooth muscle cells and the endothelial cells. And we know that phosphate levels and survival are closely correlated. That's a study by Kestenbaum's group, again in Seattle, showing the higher the level of phosphate, the higher the individual risk of the patient with chronic renal failure. So if we know all that, what are our therapeutic options? Well, first of all, and that's been a standard of therapy, is to reduce the amount of phosphate in the diet. And the second option, of course, is to add a phosphate binder. Now with the diet, there's a problem because diets that are low in phosphate are also low in protein, and particularly for our patients on hemodialysis, we often want them to have a diet high in protein. And the other thing is that there's no real study proving that a diet low in phosphate really improves things. In fact, this study came to a different conclusion, though it had a number of methodological problems. But all in all, the phosphate restriction is not of proven efficacy. What about the phosphate binders? There are a number of phosphate binders out there. The calcium-based phosphate binders, sevelamer, of course, and lanthanum, aluminum is another one that's available. All in all these phosphate binders are efficient. They're efficient in reducing the phosphate levels. There's some variability, of course, but if the patient takes them regularly, they're pretty much efficient. Now, in contrast to basically all other phosphate binders, being it aluminum, lanthanum, or calcium, sevelamer has the big advantage that it's not being absorbed in the gut. It stays in the gut. There's no absorption of sevelamer, whereas the other phosphate binders, and that of course includes the calcium-based binders, there's an absorption of calcium in that case, something that's not really wanted if the patient is at risk for vascular calcification. So what do the guidelines say? Well, the old guidelines, the KDOQI guidelines, said not more than 1.5 grams of elementary calcium should be added every day. However, if you look at a regimen where the patient takes calcium-containing phosphate binders, that already results in a load of 1.4 to 1.8 grams of calcium per day. The other thing is the dialysate calcium. Now, in Germany, at least in most centers, we have a standard dialysate calcium of 1.25. But not that long ago, it used to be 1.5 or even 1.75 millimole per liter. And in all these regimens, you have a positive calcium balance, something not wanted in patients with vascular calcifications. And of course, you have the problem of vitamin D therapy. Many patients require vitamin D therapy, which will increase the reabsorption of calcium even more. And there's increasing evidence that too much of calcium is not good. It's not good even for the general population.